20 years of age, both.
Yes, sir. And the exertional breathlessness, that is also from 20 years of age.
Yeah.
Episode of hemoptysis for last 2 months.
Yeah. What are the possibilities that you can think about?
Sir, so female patient and started bluish discoloration at the age of 45 years. 25 years.
Not
25 years of age.
No.
20 years of age, sir. Associated with exertional breathlessness.
Yes.
Sir,
what are the possibilities that you can think about?
Yes, sir. Sir, because the age is at the age of 20 years, with bluish discoloration, first come in my mind is, sir, Eisenmenger physiology due to the post-tricuspid shunt. Okay.
The post-tricuspid shunt, Eisenmenger syndrome. Okay, very good. Anything else?
And sir, female patient, 20 years of age, sir, I will also think about idiopathic pulmonary arterial hypertension.
Very good. Then how can they become blue?
Yes, sir. That is one. Hemoptysis and breathlessness.
No, sir. Yes, how can they become blue? Can something open up?
Outer pulmonary collaterals.
Outer pulmonary collaterals, no. That is, I don't know in what situation you get outer pulmonary collaterals.
PFO is opened, sir.
Yeah. If there is a opening of the PFO, and there can be if there is a significant right to left shunt, these patients can be bluish. Okay.
And Epstein anomaly.
Yeah, very good, excellent. Epstein anomaly. How can the Epstein anomaly present at this age?
Sir, Epstein anomaly.
If you look at the Epstein anomaly, what are the how does the cyanosis occur? And
the cyanosis is bimodal in origin.
Okay, yes.
Sir, in the at first, sir, because the neonatal pulmonary arterial hypertension has not regressed, at that time, sir, patient gets right to left shunt at the level of ASD or ASD, sir.
Why? Why?
Sir, because Epstein anomaly is usually associated with ASD.
Yeah, that's right. But why is this right to left shunt?
Sir, because sir, regression of primary pulmonary arterial hypertension takes time to regress.
What is the pattern of regression of pulmonary arterial resistance? Can you describe the timing?
Yes, sir. Sir, with the first breath, 50% reduction.
Yes.
And after 6 weeks, it reaches almost to the normal.
It takes only 2 weeks, 2 to 4 weeks.
Okay, sir.
6 weeks is required if the patient is having a communication. If the patient is having a PDA or VSD, post-tricuspid shunt, it will take longer time and may take about 6 to 8 weeks. But normally it takes only 2 to 4 weeks. So first breath, almost 50% fall in pulmonary vascular resistance, and over the next 2 to 4 weeks, it reaches the adult pattern. Okay, so what is happening in Epstein's anomaly to have cyanosis in early childhood?
So cyanosis to have in early childhood, it has to be, sir, from right to left shunt.
Okay.
Sir, in Epstein anomaly, there is a atrialization of the right ventricle.
Okay.
And RV is of very low volume, and there is a low pressure TR.
Okay.
But sir, during the neonatal period, because the pulmonary arterial hypertension has not regressed, as a result, sir, this TR and sir, the flow from the RA to LA occur.
Yeah, you can say that your explanation is going in the correct direction. You have to say that because of the pulmonary artery pressure is not completely regressed or in the process of regression, that will result in a much more prominent tricuspid regurgitation. Because the RV pressure is high, that will result in significant tricuspid regurgitation, that will distend the right atrium, and through the AST there can be right left shunt. So in the immediately after birth, the child with Epstein's anomaly can have bluish discoloration. Then what happens?
Sir, after that, sir, there is a regression of the pulmonary pulmonary hypertension. So, sir,
better to use the word pulmonary vascular resistance. Along with that, the pulmonary arterial hypertension, pulmonary artery pressure also comes down.
Yes, sir.
That
as a result, the right to left shunt is regressed. Sir, now
no, you have to explain it. No. You have to say that consequent to this, there is a reduction in the tricuspid regurgitation. Because the tricuspid regurgitation is depending upon the RV pressure. And when there is a regression of the pulmonary vascular resistance and pulmonary arterial pressure, that will result in less of RV pressure, systolic pressure. That will result in less of tricuspid regurgitation. That will result in less of right atrial pressure, and the right left shunt can disappear or completely disappear, and that can result in
disappearance of cyanosis.
Disappearance of cyanosis. Okay, very good. Then,
sir, then after the sir, when there is a RV failure,
okay,
at that time, sir, again there is a development of the pressure in the RA right side increases. So
very good.
There will be again development of
because of the LV dysfunction, RV dysfunction, the RV diastolic pressure rises, and consequently right atrial pressure also goes up, and that can result in right left shunt, and the child can become, or the adult can become cyanosis again. So the cyanosis in a patient with Epstein's anomaly can occur in early childhood or immediately after birth, and then it regresses. And depending upon whether the patient is developing RV dysfunction or not, the individual can develop cyanosis. Okay, so Epstein's anomaly. Anything else?
So then, sir, other causes of cyanosis at the age of 20 years with exertional breathlessness. Sir, like sir.
Is there any
single ventricle physiology? Sometimes, sir, single ventricle physiology can live up to, sir, but 45 years of age does not live, sir.
Can it be a double-ordered right ventricle?
Yes, sir. Among the top physiology variants, sir,
what are the modes of presentation of double-ordered right ventricle?
Yes, sir. Sir, double outlet right ventricle, sir, if it is a, sir, it all depends on the pulmonary flow.
Okay.
Sir, so patient can present with the cyanosis, cyanotic spell, and sir, one special type of DORV, sir, that variant in which, sir, there is a preferential flow. Then, sir, we may not get the toxic big anomaly, in which is, sir, we may not get the cyanosis so prominent. No, sir, I am opposite telling. Yes, sir. So there is a, sir, in toxic being anomalies, sir, patient may present cyanosis.
Okay.
Yes, sir. Sir, so DORV with toxic being anomaly type can present with bluish discoloration, but I don't know, sir, about breathlessness.
No. See, what are the modes of presentation of double-ordered right ventricle? That's my question. Any one of you, any student who would like to volunteer? Eknath?
Sir, patient be present with sinus at birth and the failure.
Okay.
If the patient is having the toxic being anomaly.
Very good.
If then the aorta is more than 50% override.
Always in double-ordered right ventricle, there is always more than 50% override. Yes, always it should be there. That's one of the criteria for the diagnosis of double-ordered right ventricle.
Yes, sir. To differentiate from cough.
What is the other criteria that you look for?
Sir, anterior and cephaloid displacement of the septum, sir.
They are actually side by side. There can be
parallel both.
There can be side by side. And third is that you will be able
to mitral and aortic
discontinuity, sir.
Yes, you will be able to see subpulmonic and subaortic corners. Both the
subpulmonic will be persisting.
Both the subpulmonic region as well as subaortic region will have a corners.
Yes, sir. This patient will also have breathlessness because of the large VSD, sir.
Okay. Now, but I want to know what are the 4 modes of presentation of double aortic right ventricle. One you have already said they can present
cyanosis.
They can present the early cyanosis in toxic being anomaly, where the physiology is something like transposition of great arteries.
Yes, sir. Yes,
2.
Sir, 2 like top physiology, sir.
Top physiology, yes. They can have, if there is a VSD PS, then already VSD is there. Along with that, if there is a PS, and that can present something like a top physiology. Only difference is that the pulmonary stenosis in double aortic right ventricle is very often valvular, while in the Trojay file, as you know, it is more than 90% it is subvalvular. Okay. 3. Third presentation.
I don't know, sir.
Anybody else in the group? Third presentation, patients can present like VSD because of the torrential flow into the pulmonary artery from the aorta, from the right ventricle, and preferential flow of blood from the left ventricle to the aorta. The patients can behave something like a VSD with a torrential flow. They may not be even cyanosed, or sometimes only on exertion they may be there. You will be able to detect a tinge of cyanosis. And fourth, these patients can present with pulmonary arterial hypertension and Eisenmenger physiology. So a double aortic right ventricle can have 4 types of presentation. One, something like a transpositional great artery physiology, toxic being anomaly. 2, tetralogy parallel physiology. 3, large VSD like physiology, and 4, Eisenmenger physiology. So there are 4 presentations of double aortic right ventricle. So here also you can consider that this patient might have an early as behaved like a VSD, and over a period of time the patient might have developed pulmonary arterial hypertension and Eisenmenger syndrome, and now the presenting with cyanosis. So that also can be kept in mind. Anything else? What happens to patients with collateral flow? Sometimes patients can have huge collaterals, and
hemoptysis can occur.
If some of these collaterals do develop thrombosis or develop any obstruction, then the pulmonary blood flow can come down, and sometimes these patients can become more and more blue. Okay, what does the hemoptysis tell you?
So hemoptysis is of recent onset. It is around 45 years of age has developed.
Okay.
So sir, the cause for hemoptysis, sir, maybe, sir, either, sir, pulmonary venous hypertension, pulmonary arterial hypertension, or infection, or embolism. So, sir, here, but, sir, looks like, sir, that maybe, sir, patient has developed pulmonary arterial hypertension.
Okay. Can the patient with the Eisenmenger syndrome develop hemoptysis?
Yes, sir. It develops
yes, sir.
hemoptysis.
Yes, sir.
Yes. What is the reason?
Hyperviscosity.
Oh, of course. But more important than that, what is the pathology of Eisenmenger syndrome? Can you tell me the pathological changes in the vasculature in a patient with Eisenmenger syndrome? Stage 1, stage 2, stage 3, stage 4? Any one of you? What are the 4 stages of pathological changes of pulmonary arterial hypertension? Stage 1, what happens? There is
So increased flow and dilatation of the.
Yes, what are the pathological changes?
Medial hypertrophy.
Medial hypertrophy, very good. The stage 1 is medial hypertrophy. Stage 2? Stage 2.
Interval proliferation.
Interval proliferation and again start developing fibrosis. Stage 3?
Due to fibrosis, lumen get occlusive.
Yes, and also they can have peribronchial inflammation. Fibrosis progressively leads to peribronchial inflammation. Stage 4?
The plexiform lesions,
Plexiform.
muscular.
Yeah, they can go for vasculopathy, where there can be vascular aneurysm, plexiform malformations. So vascular changes can happen, and at this stage there can be hemoptysis. So stage of hemoptysis can occur in patients with severe pulmonary arterial hypertension, where there is stage 4 pathological changes. So Eisenmenger syndrome and primary pulmonary arterial hypertension are two situations where the vascular changes can progress to this stage 4 situation, and that can result in hemoptysis. So hemoptysis can go with patients with Eisenmenger syndrome. Yes, hemoptysis can occur in also patients with cyanotic angle heart disease, where there are plenty of collateral flow. For example, pulmonary atresia patients, where there is plenty of collaterals coming from the aorta into the lung or into the bronchial, into the pulmonary vasculature. Sometimes can cause, because of the higher pressure in the aortic collaterals, some of these small vessels of the pulmonary arterial system can actually rupture, and that can result in hemoptysis. So hemoptysis can occur in patients with low flow cyanotic angle heart disease, but also can occur in Eisenmenger syndrome. Okay, right now go to the rest of the story.
Okay, sir. History of present illness.
Okay.
Patient noticed bluish discoloration which increased on exertion from 20 years of age. She noticed that her whole body turned blue when she exerted. Associated with this, she started feeling breathless on exertion. Class 2 NYHA. The bluish discoloration progressively increased, and by the age of 25, she observed bluishness of her whole body even at rest. And she noticed that her face is relatively less blue, and her exertional breathlessness also worsened, and she became breathless with less than normal routine activities. Class 3 NYHA. No orthopnea or PND, and she consulted a cardiologist who told her that she has a heart disease from the birth, and bluish discoloration is due to the mixing of impure blood with the pure.
Okay. Go ahead.
Yes. She is getting episode of hemoptysis for the past 2 months, and she had altogether 4 episodes, always preceded by cough. In one occasion, she had fever and cough for 2 days before she had hemoptysis, and the frank blood, small in quantity. No history of syncope, no history of palpitation or edema of leg, no history of cardiac pain or intermittent claudication of upper or lower limbs. And the doctor prescribed her 3 medicines, out of which one was blood-forming tablets. And the tablet did not increase the urine output. And the doctor also told her that her disease has progressed so much that surgery is not possible. She had undergone removal of blood on a few occasions.
Okay. So from the history of present illness, what are the conclusions that you can draw?
Sir, first said that it is not a left-sided heart disease because the PND and orthopnea are absent.
Okay, no, you cannot use that word. But PND, mostly it is a right-sided problem because the absence of PND and orthopnea. Okay, very good. Yes.
And so, second, sir, from this it looks that there is a hyperviscosity state for which blood letdown has been done, and because of that there is maybe, sir, this deficiency of iron, and for that, sir, she was given iron tablets.
Okay, so she has got
hyperviscosity state,
polycythemia, and yes, for that the doctors advised venesection, and that what is the need of venesection in these patients when there is polycythemia?
Sir, that causes, sir, hyperviscosity syndrome, mainly involving the neurological symptoms like, sir, dizziness, or, sir, venous thrombosis, cerebral venous thrombosis.
Yes, sir. So when there is polycythemia, that can result in cortical venous thrombosis, or the thrombus to the brain sinuses. So venous sinuses can develop thrombosis. So these patients, because of the high viscosity, can have a lot of cerebral symptoms: headache, vomiting, dizziness. All these things can happen. Okay. So at what level will you advise bloodletting?
So more than 20 gram, or, sir, Paxil volume more than 65.
Yeah, when the Paxil volume is more than 60 or hemoglobin more than 20, one of the two, there is an indication for bloodletting. And when the blood is let out, you should simultaneously give.
Simultaneously, normal saline has to be pushed.
Normal saline should be infused so that the blood volume is retained and the polycythemia is brought down. Okay, very good. Yes. So yes.
And because of that, sir, there is a relative iron deficiency.
Yeah, there is a possibility that frequent removal of the blood can result in iron deficiency, and these patients may require supplementation. Then a past history.
And, sir, so, sir.
Sir.
Yes.
Sir, one more point, sir. In this, it is the patient notices that her face has cyanosis. So, in this Eisenmenger, we have to consider possibility of PDA with Eisenmengerization. It can give a clue to that, sir.
You mean say that because of the, but we cannot always believe the patient. So, but the patient says that her face is less blue, so you are thinking that it could be Eisenmenger, could be PDA.
So, like differential cyanosis can be considered based on
okay,
that,
very good. That's a very good point. So, since from the story, there is a possibility that we may carefully look for the evidence for differential cyanosis. Very good. Excellent point. Very good point. Okay, yes. Okay, now we'll go to the past history and then we'll discuss further. Yes, go ahead.
Good evening, sir. Good evening, sir.
Good evening. We missed you in the last class.
Yes, sir. Actually, thesis was going on, sir. That's all.
Have you submitted your thesis?
Yes, sir. Yes, sir. Submitted, sir. Submitted, sir.
Okay.
Sir, can the single ventricle physiology can also be thought upon? Single ventricle physiology, because they also are known to have survived more than 40 years.
Single ventricle physiology, usually they will be cyanosed from birth, and because the survival in single ventricle physiology, what is the single thing which decides longer survival?
Some mixing of the blood and.
There is a what type of a cyanotic problem is single ventricle?
Admixture physiology. Admixture physiology.
Admixture physiology. So they will have cyanosis from early childhood and they continue to be cyanotic. But what is the
pulmonary flow? Sir, pulmonary blood flow.
There should be a controlled pulmonary flow, because if there is no pulmonary stenosis, these patients cannot survive.
Cannot survive.
If there is a pulmonary stenosis and if it is sufficiently not very severe, at the same time moderate pulmonary stenosis, some of these patients can survive because of there will be adequate pulmonary blood flow. At the same time, there is no chance of developing pulmonary artery hypertension, and these patients can have a good survival, a longer survival. But that's very unusual, because majority of these patients with single ventricle will have associated what?
BSD.
There is no question of BSD because it is single ventricle. These patients can have transposition also. So how do you diagnose transposition in a single ventricle? How will you diagnose transposition in a single ventricle?
Sir, from rudimentary ventricle. Sir, which will be, sir, in case of transposition, it will be, sir, The rudimentary ventricle will be on the left and sir, it will be according to the rudimentary ventricle. We have to.
Okay, if there is a rudimentary ventricle, yes, you can. Sometimes you can see the RV outflow. This infundibulum can be seen, and if the infundibulum is seen, then you can diagnose whether the patient is having transposition. But what you carefully look for is for sub-aortic conus. If you are able to see a sub-aortic conus, then that patient has got transposition. And if the patient is having a conus and the conus is attached to the pulmonary artery, then that patient is not having any transposition. You must look at the relationship between the aorta and the pulmonary artery. If the aorta is anterior, then you know that indicates there is
Transposition.
So these are the two important points. One, the aorta to pulmonary artery relationship and the subpulmonary conus. But many of these patients with single ventricle can have RV outflow. The infundibulum can be there, and if the infundibulum gives rise to the aorta, then you are sure that this is a transposition physiology. Okay, so as Gaurav has pointed out, patients with single ventricle also can have can survive, provided they have got an pulmonary stenosis, which just is enough to prevent pulmonary arterial hypertension. At the same time, allows adequate blood to flow to the lungs. But if the patient is not having any pulmonary stenosis, these patients will develop pulmonary arterial hypertension, Eisenmenger syndrome, and they will not survive. Okay, right? Yes. So we have already discussed a possibility of double outer right ventricle, where patients initially presenting something like a VSD, patients can develop pulmonary arterial hypertension and later present with Eisenmenger syndrome, and that may be a mode of presentation, and that possibility we have already discussed in this case.
Sir, what is this one? There is no history of syncope. Sir, this is also important.
Why it is important?
Sir, because sir, then we can rule out, sir, like sir, ostium primum ASD or sir endocardial cushion defect.
Why are you saying that you can exclude
sir,
that?
because sir, in those cases also we get cyanosis, we get breathlessness, but sir, they are usually associated with sir complete heart, not complete heart block, but sir left axis deviation, sir increased PR interval.
So, but that will not give rise to exertional syncope.
Okay, sir. So, sir, what is the importance of this, that not having syncope? Sir, usually pulmonary idiopathic PAH gets syncope.
Yes.
But here, sir, already told that patient has got a disease of since birth.
Okay.
So, sir, cyanotic heart disease, which we can rule out if absence of syncope.
No. What are the syncope? What is the mechanism of syncope in patients with primary pulmonary arterial hypertension?
Yes, sir. It is, sir, because of the decreased cardiac output.
Oh. When these patients exert, when the patients exercise, what happens to pulmonary artery pressure?
So it will increase.
Not only increase. What is the mechanism?
So with exercise, systemic venous resistance decreases, whereas due to hypoxia, there is pulmonary vasoconstriction.
No, when there is during exercise, what happens to the cardiac output?
So with exercise, cardiac output on the left side increases.
Increase. What are the mechanisms of increase in cardiac output during exercise?
Sir, one is, sir, systemic venous resistance decreases.
Yes.
Force of contraction.
Systemic venous resistance. What is this systemic venous? Systemic venous resistance to do with the cardiac output? Afterload. There is reduction of cardiac
peripheral vascular resistance.
There is a reduction.
Afterload reduction.
Yes. One.
Yes,
two.
Force of contraction increases.
Yes. What are the mechanisms of increase in the force of contraction?
So one is increase in the preload.
Increase in the preload. And another is?
Sir, contractility increases.
Yes, the two is increase in the contractility. And also there can be increase in the heart rate.
Heart rate also increases.
All will result in higher
Cardiac output.
cardiac output. And when the cardiac output is higher, what happens to the pulmonary artery pressure? On the left side, because of the reduced peripheral resistance, when there is an increase in cardiac output, there can be increase in the pulse pressure, but the systolic pressure can also slightly go up, not significantly. But on the pulmonary side, what happens? Is there a similar vascular reaction?
No, sir. Pulmonary pressure increases.
Yeah, there is an acute rise in the pulmonary artery pressure, and that can result in symptom of
Syncope.
syncope. Okay. So what is the what happens in a patient with VSD or PDA, and what happens in a patient with ASD with Eisenmenger syndrome? Out of these three, which Eisenmenger can give rise to syncope?
Syncope occurs in all three, sir, in PDA, ASD.
Yeah, in all three it can happen, but more frequently.
But PDA more frequently it happens.
Why? What is the reason?
Because both systole and diastole.
How can there be more syncope in patients with PDA? PDA patients will have usually less of syncope.
In ASD we will get, because suprasystemic pressure can develop.
Very good. That's the point. In patients with the ASD Eisenmenger, they can develop suprasystemic pressure during, especially during exercise. The pressure can suddenly go up, and these patients can develop syncope. So suprasystemic pressure and the symptom of syncope is more frequently associated with ASD Eisenmenger than other two. Why in the other two there is no suprasystemic pressure?
So because, sir, here the equalization of the pressure occurs at the whereas, sir, in case of ASD, sir, RV is there to bear the pressure of the pulmonary pulmonary arterial pressure.
In a patient with PDA or VSD, when the pulmonary artery pressure goes up, what happens?
So there will be reversal of shunt.
Yeah, there will be more flow from right to left, and then the right side can get decompressed.
Yes.
When a patient with ASD, if there is a increase in pulmonary artery pressure, what happens?
Sir, there is a RV is compliant. Till the RV fails, sir, there will be, sir, no reversal of shunt at the ASD. Because there is
in ASD, the systemic circulation is completely isolated from the shunt flow. There is no connection between the shunt flow and the systemic circulation. Because of that, when the pulmonary artery pressure goes up in a patient with ASD, there is no decompression, and they can actually go to suprasystemic pulmonary artery pressure. And exertional syncope is more frequent in patients with the ASD than with VSD and then with PDA. PDA, the chances of the exertional syncope is very uncommon, because there is a connection between the systemic circulation and the pulmonary circulation, both during systole as well as during diastole. And even if when there is a rise in pressure, immediately it can be decompressed to the systemic side. Second point, usually the cerebral circulation is not very much affected, because the cerebral circulation is still oxygenated blood in a patient with PDA, and cerebral symptoms are much less in a patient with PDA than with VSD. In VSD, the sinus blood or the blue blood can flow to the brain, but in a patient with PDA, the blood flowing to the brain is still oxygenated and less of symptoms secondary to hypoxemia. Usually the deoxygenated blood is shunted to the lower part of the body in patients with patent ductus arteriosus Eisenmenger, while the cerebral circulation upper limb always get the oxygenated blood. So it can happen, the exertional syncope can happen in Eisenmenger syndrome, but it is more frequently seen in ASD. That is because of the suprasystemic pressure can happen in ASD, and there can be exertional syncope. Whenever there is an exertional syncope associated with pulmonary arterial hypertension, you must always think of the possibility of primary pulmonary arterial hypertension. Okay, right. Yeah. Any other point to be raised? Okay, past history.
Informant mother, reliable, born of non-consanguineous parents, preterm delivery. No heart disease was detected.
Why preterm delivery is important?
Sir, yes, sir. Because, sir, in this case, sir, we can think about the PDA.
Yeah, why in preterm babies there is a higher incidence of PDA?
So closer of the PDA need to
because lung maturity is not there, sir. So when the baby is born, so PDA closure is due to oxygenation. So oxygen lead to closure of the PDA. But if the lungs are immature, patient will not have a good oxygenation, which causes the closure of PDA.
No, that is not the reason, because still the child has to get adequate oxygen. Otherwise, child will be very sick. So if the oxygenation is not taking place, then you will support with oxygen therapy, and the oxygen saturation will be maintained.
Sir, in PDA, the ductal tissue is less responsive to oxygen compared to term infants.
Why it is so? What is the reason? Any one of you? The smooth muscles, which actually close the ductus arteriosus, develop near about tape. It usually develops during the near about within last near about the term, maybe 36th week or maybe 34th week. So the development of the smooth muscles, which are sensitive to oxygen and which actually constrict and close the PDA, develops very late in the intrauterine life, near about term. So in a preterm baby, there may not be there is a possibility that the smooth muscles, which actually lead to the closure of the ductus arteriosus, might not have developed, and because of that, there is a higher incidence of PDA in preterm babies. Why there is higher incidence of PDA in rubella syndrome?
It prevents the contraction of smooth muscle.
Yeah, actually the virus destroys these smooth muscles. Virus can attack these smooth muscles, which ultimately lead to the PDA, the ductus closure can be partly destroyed by the virus, and that is why these patients have PDA. That is why the PDA in a patient with rubella syndrome is a large PDA, because there is no vascular response at all, and these patients can have large PDA. So PDA, the tissues which ultimately lead to the PDA closure develops near about term. And in a preterm baby, these smooth muscles might not have developed, and there is a higher incidence of patent ductus arteriosus in preterm babies. Okay, very good point. Yes, go ahead.
No heart disease was detected at birth. The pediatrician detected a heart murmur when she...
Why the no heart disease detected at birth in a patient with PDA?
So because of high PVR, the shunt is not established at birth.
Yes, because of the pulmonary vascular resistance is very high, the shunt may not be established. Shunt will get established only when the pulmonary vascular resistance regresses to a particular level, so that there can be a good flow across the duct, and you will be able to recognize the murmur. Okay, right? Yes.
The pediatrician detected a heart murmur when she was taken to him for fever. The child used to get respiratory infection at the rate of about 6 per year for the first 2 years, and she had to be hospitalized on few occasions.
What does that mean?
So it means, sir, this is left to right shunt and fulfills the criteria for recurrent respiratory tract infection of infancy.
Yes, what is the criteria for?
The criteria is, more than 3 lower respiratory tract infection in 1 year or more than 5 in 2 years, one of which the patient needed IV antibiotic therapy.
And also hospitalization.
Hospitalization, yes.
Okay, yes.
She had to be hospitalized on few occasions, and the doctor advised cardiology consultation. And the cardiologist told the patients that the child is having heart disease from birth, and consequently more blood is flowing to the lungs, and she requires a surgery to correct the defect. The advice was given at the age of 3 years, and the parents were afraid of heart surgery, and they consulted an Ayurvedic physician who prescribed medicine and told the parents that the defect can become smaller and can also close spontaneously.
So what are the defects which can close spontaneously?
PDA.
Sir, VSD, muscular, small VSD. Sir, PD also can close.
Okay. Yes.
Sir, PFO.
What about ASD?
Yes, sir. Sir, small ASD or PFO sir, can close.
Yes. What type of ASD can close actually?
So, ostium secundum.
Ostium secundum, right? But
less than 6 mm.
Yeah. Any special characteristic which will make you think that most likely this will close?
So, if the blood flow through the ASD is less than 1.5.
No. This is why very large ASDs cannot close, but small ASD you have already mentioned.
8 mm, sir, 8 mm.
6 to 8 mm ASDs can close. But the additional point is that ASDs associated with the intrathecal septal aneurysm has got higher chance of closure. Almost 50% of ASDs which are associated with the intrathecal septal aneurysm can close. And they close before what age? The ASDs which are to close usually closes before the age of 1 year, and after the age of 1 year, the chances of ASD closing is very unlikely. So 50% of the ASDs which are associated with the intrathecal septal aneurysm can close, and usually the closure occurs within 1 year. And usually the ASD which closes are usually less than 8 millimeter in diameter. Okay, right? Yes. What about VSD?
Some of the perimembranous VSD also can close.
Yes, the perimembranous VSD also can close. Perimembranous as well as muscular VSD can close. And when do they close? And what is the mechanism of closure of VSD?
The mechanism, sir, once sir, septal leaflet of the tricuspid valve can, because of that can close. Sir, aortic sinus.
Yeah, the septal leaflet of the tricuspid valve can get attached to the VSD and close it, right? 1, 2.
Sometimes, sir, in case of infective endocarditis.
Yes, people have described that sometimes infective endocarditis vegetations can significantly bring down the VSD or even sometimes close it. Okay, 3.
Sir, one is, sir, after the development of double chamber right ventricle.
Other mechanisms of closure.
Prolapse of aortic cusp can close the.
Yeah, sometimes the prolapse of the aortic cusp into a small VSD can close it, but then it is at the expense of aortic regurgitation. Yes.
And in muscular VSD is direct apposition of the.
Yeah, in muscular VSDs as well as in small perimembranous VSD, there can be direct apposition and it can close. Yes. There can be sometimes in subaortic VSD, there can be aneurysm formation, and these aneurysms can close the VSD. So there are multiple mechanisms of closure of VSD. They are, Saroj, can you repeat?
Yes, sir. Sir, septal leaflet of the tricuspid valve.
Yes.
Sir,
no, you have to say that septal leaflet of the tricuspid valve can get stuck to the
sir, VSD.
Yeah, which are the VSDs which are likely to close? of the locations, which is the VSD, which is likely to close.
So this will be, sir, subaortic, sir.
The perimembranous or subaortic VSD. And 2,
Muscular.
VSD. Which are the VSDs which are unlikely to close?
Sir, outlet VSD.
Outlet VSD, the subpulmonic VSD and inlet VSD. Subpulmonic VSD and inlet VSDs are the two VSDs which are unlikely to close. Okay. So what are the 6 or 7 mechanisms by which the VSD can close?
So then, sir, infective endocarditis can
put infective endocarditis as low in the list.
Yes, sir.
Because there
then
is
the
a
sinus of Valsalva.
Yes.
Then prolapse of the
sinus of Valsalva.
No, sir, sorry. So prolapse of the aortic sinus.
Okay, not sinus, aortic cusp.
Aortic cusp.
Aortic cusp can prolapse into the. Does it prolapse in a small VSD or large VSD?
Sir, large VSD it will prolapse.
Eh?
Sir, if it is
what is the mechanism? What is Venturi effect? Is it higher in a small VSD or a large VSD?
Oh, sir, small VSD.
Small VSD. Venturi effect is depending upon the velocity of the jet.
Yes, sir, jet.
So it is depending upon the size of the VSD, and if the VSD is small, they will have much greater velocity of jet, and that can result in Venturi effect. And the aortic, the right one, actually can get pulled to the VSD, and it can partially close the VSD. Sometimes it can completely close the VSD, but it's at the expense of aortic regurgitation. Okay, right? Yes. Third. Aneurysm. Muscular VSD as well as perimembranous VSD, small ones, can sometimes close by direct apposition. Very good. 4.
Septal aneurysm formation and
yes, there can be aneurysm formation, fibrous tissue aneurysm formation, especially in perimembranous aortic VSD, and that can close the VSD. Okay, right? Yes. Anything else?
Ask infective endocarditis.
Infective endocarditis. So sometimes infective endocarditis can give rise to large vegetations, and some of these vegetations can be stuck to the VSD and can result in a VSD closure. So there are multiple mechanisms of VSD closure, and the VSD can also come down in size. And what is the age at which they close maximum, and beyond which age the closure chance is very, very unlikely?
2 to 3 years.
No, sir, maximum 8 years, sir. Maximum 5 to 8 years. VSD closure.
No, wrong. Anybody who knows what is the chances of closure of VSD depending on the age of the patient? 80% of the VSDs which are to close by 2 years. Actually, for the VSDs which are to close, around 60 to 70% close within 1 year, and another 10 to 15 or 20% close in the next year. So by second year, about more than 80% of the VSDs which are to close has already closed. So subsequently, the closure chance is very low, and after the age of 8 or 10, the VSD is unlikely to close. So the majority, more than 80% or 80 to 90% which are to close, will close before the age of 2, out of which maximum is during the first year, which may be up to 60 to 70%. And then another, the remaining VSDs which are likely to close occur a period from 2 to 10 years. After the age of 10 years, the chances of a VSD closure is practically nil. Okay, right? Yes. Can the PDA close? And what age does the PDA close?
The functional closure and the anatomical closure.
Yes.
So, sir, within 72 hours, the functional closure.
Very good. Anatomical closure?
Sir, anatomical closure.
Yes.
Anatomical closure by 1 week.
2 to 3 weeks, sir. 2 to 3 weeks.
Yes, usually by about 2 weeks. So the functional closure is by about 2 to 3 days, and the anatomical closure is by about 2 weeks. Okay, right. So in very small PDA, it has been reported that there can be a closure of the PDA. And similar to the VST also, usually the closure occurs before the age of 2 years. Okay, so VST, PDA, AST all can close, but the usually smaller ones can close. And PDA, AST usually before the age of 1, PDA before the age of 2, and VST and PDA before the age of 2. Okay, right. Let's go ahead.
No history of rheumatic fever in the past.
Okay.
Family history, no history of congenital heart disease in the family. No
Okay.
history of maternal infection during pregnancy. Habits, vegetarian, and no special habits.
Okay. Okay. Gaurav, would you like to discuss the story and tell us the diagnosis?
Sir, one squatting history, I was thinking it is squatting history.
Yeah, that should have been mentioned as whether there is a history of squatting. So actually, there is no
Yes,
history of
sir, that
squatting. There's no history of squatting.
Yes, sir. Then, sir, positive points is, sir, she's having a bluish discoloration from 25 years of age, sir. Now she's 45. So
20 years of age. Okay.
So we have to think for reasons causing bluish discoloration from 20 years of age. And she's also giving a history of recurrent LRT episodes in childhood. So my first will be, sir, this pre-tricuspid and post-tricuspid shunts. Sir, either it should be.
Which one is likely to give rise to cyanosis at the age of 20 years?
Sir, at the age of 20 years, sir, VSD, sir, VSD and PDA. PDA also, sir.
Okay.
Yes.
PDA occurs at 18 years of age.
Any time in the second decade. So we cannot be very specific, 18, 19. It can be anywhere from 12, 13 up to 20 years. That is the usual age during which these patients develop pulmonary arterial hypertension and can go in for Eisenmenger physiology and may manifest as cyanosis towards the end of second decade. Okay, right? Yes.
So VSD, PDA is in and ASD is out. ASD is lower in the list.
Why?
Sir, they will manifest around 35 years of age.
But there is a small percentage of patients with the ASD who have been reported to develop Eisenmenger early in life and are present with cyanosis. And what is this group due to? The Paul Wood has described a group of patients who can develop cyanosis in a patient with the ASD. And what is his contention? What is his explanation for this special physiology?
Yes, sir. They have associated pulmonary hypertension. Associated.
Yeah. According to Paul Wood, these patients may be having a pulmonary arterial hypertension
and also Down's.
Yeah, Down syndrome. Yes, that may be related to the genetic changes which are similar to primary pulmonary arterial hypertension, and these patients can present with the pulmonary arterial hypertension, and basically there may be a possibility that these patients may be having a Eisenmenger physiology also. A primary pulmonary arterial hypertension like genetic changes also. Okay, so the patients with ASD, a small percentage. This is about 5 to 10% of patients with ASD. Okay, right. What else?
Sir,
of the VSD and PDA, do you have a clue to make any diagnosis whether it is VSD or PDA?
Preterm delivery is there.
Yes,
preterm likely to be PDA, sir.
Why?
Sir, one, sir, that facial, there is a differential cyanosis. The face is spared.
Yeah, she says that there is less of bluishness of her face. That if her observation is correct, there is an additional point for us to think that the patient may be having.
And sir, premature baby.
Yes, both put together, there is a possibility that this could be a.
And sir, the murmur was not detected at birth.
Yeah, so that can happen with VSD also, but the points are more in favor of PDA because of the one important observation by the patient that their face was less cyanotic or less bluish compared to other parts of the body. And also the preterm babies have more chances of having PDA than VSD. So that is something which is an additional point for us to think that the child might have had PDA. and subsequently the patient developed Eisenmenger physiology and now presenting with pulmonary arterial hypertension and right left shunt. Okay, right, yes. And also further clue is obtained because the patient observed that her face is less blue compared to the rest of her body. Okay, right, yes. Any additional point?
Sir, and TOF I will keep down because no squatting episode, so TOF I will keep down only.
Is there a possibility that patients with TOF may not have a squatting history?
Yes, some.
Yes, studies have shown that some of the patients with the TOF physiology may not have squatting, and also some of the patients with Eisenmenger syndrome can have squatting.
Can have squatting.
So not commonly, but rarely. So the squatting does not take you away from the diagnosis of Eisenmenger if everything else is suggestive of Eisenmenger. That is, of course, that is rare, but not very frequent. So, but that can be kept in mind. What is the Eisenmenger physiology? What is the what happens when the patient is squatting?
So there is
What are the hemodynamic changes of squatting?
So there is a
yes, yeah.
so there is the femoral artery get compressed, sir, and that lead to the increased afterload. And
yes.
this increased afterload,
kinging of the lower limb vessels resulting in increase in the afterload. Yes.
Second thing, due to compression of the abdomen, the venous return has also increased, and that increased venous return that lead to the increased pulmonary blood flow.
Okay, there can be increased pulmonary blood flow because of the increase in the venous return. The third point.
The abdominal viscera are more have more saturation.
Okay, the venous return from the abdominal viscera, especially the kidneys, have got a much higher, significantly higher venous oxygen saturation. Okay, so what?
Sir, as a result, sir, there will be more oxygenated blood will be reaching to the heart. Sir, yeah. RB and then, sir, right to left shunt, it means to the aorta.
Okay, so the more oxygenated blood reaches the right ventricle, so right side of the heart. So even if these patients are having right to left shunt, because of the blood in the right side is more oxygenated compared to the previous situation, the desaturation of the systemic blood is less striking, because the more oxygenated blood is coming to the right ventricle, more oxygenated blood is shunted from right ventricle to the right ventricle or from the right side to the left side, and because of that, the desaturation of the systemic blood is relatively much less. So these patients, when the three mechanisms, which are one, the kinging of the lower limb arteries resulting in greater elevation of the pulmonary systemic vascular resistance, hence the right and left comes down. Two, these patients can have an increase in the venous return, more oxygen, more blood in the right side of the body, more blood to the lungs, and the oxygen saturation goes up. And three, the blood coming from the venous blood coming from the abdomen, especially the kidneys and abdominal viscera, are more oxygenated than the blood coming from the lower limbs. When there is a kinging of the vessels, lower limb venous return is cut off, while more blood is coming from the abdominal viscera, which is more oxygenated. And if the more oxygenated blood is reaching the systemic circulation as right to left shunt, that can result in less of desaturation. So three things are happening. So the decrease in the increase in the venous return, increase in the systemic vascular resistance, decrease the increase in the venous return, and decrease in the venous return from the lower limbs, while increase in the venous return from the abdominal viscera, which results in a higher higher oxygen saturation of the venous blood, and that will result in, even if there is a right to left shunt, there will be less of desaturation. Okay, so squatting has there are multiple benefits for squatting.
Excuse me, sir. Sir, one more DD, can it be ASD Lutembecker or far-fetched?
What is the biggest point against the diagnosis of ASD Lutembecker? Any one of you?
Cyanosis is there, sir.
Cyanosis present.
Yes, cyanosis is present. Because of the higher left atrial pressure, the Lutenbacher in a patient with even a Lutenbacher patient, the cyanosis development is very, very unlikely because because of the mitral stenosis, these patients' left atrial pressure is high, and always it is the left to right shunt and not the right to left shunt. There is an obstruction to flow to the left ventricle because it is the ease of flow which decides the shunt. So in a patient with ASD, when there is associated mitral stenosis, there is a difficulty of flow from the left atrium to the left ventricle, and preferentially it flows from the left atrium to the right ventricle, to the right atrium to the right ventricle. And because of that, the possibility of a cyanosis in a patient with Lutenbacher syndrome is extremely low or practically nil. Right. Okay. Yes. Is it clear to you, Gaurav?
Yes, sir. Yes, sir.
Okay.
And sir, Eisenmenger also. Sorry, this there is abstinence also is because there is.
Yes, abstain is a possibility that you should discuss, and which we have already discussed. Abstain. How can you explain abstain? We have already actually Saroj has already discussed what happens in abstinence anomaly and how there can be a late cyanosis in abstinence anomaly. So abstinence anomaly can definitely be considered.
So only then for four differential diagnosis, sir. VSD, PDA, and
can this be? This can also be a possibility of a double outer right ventricle also is possible, where the patient has developed permanent arterial hypertension and now is presenting as Eisenmenger syndrome. So that possibility also should be kept in your mind and should be carefully looked for when you are looking at the echo of these patients. Okay, right. Now let's go to the physical findings. Okay, right. Yes.
General examination.
Okay.
Patient not dyspneic, no pallor, conjunctiva and tongue are red, clubbing and cyanosis, right upper limb and both lower limb. Left upper limb is not cyanosed. Tongue and the lips are not blue. Left upper limb has mild clubbing, oxygen saturation, right upper limb 80%, left upper limb 92%, right lower limb 79%, left lower limb 79%. No edema of dependent parts.
Okay, what is your explanation?
Sir, here sir, left upper limb is not cyanosed, clubbing is also not there. So sir, there is a sir PDA, but sir there may be a sir TGA physiology, sir, together with sir.
TGA physiology.
No, sir. PDA with sir preductal and postductal.
What is it?
Sir, it is sir postductal, but sir there will be sir why right upper limb is also cyanosed. Explanation is that sir right subclavian artery is after the PDA, sir, that leucoria or sir abnormal origin of the right subclavian artery.
Yeah, you have to think of the aberrant right subclavian artery.
Sir, aberrant right subclavian.
Aberrant right subclavian artery arising from the descending thoracic aorta. So that
distal to the PDA.
Distal to PDA. That can be the only explanation where the patient has got the right upper limb is blue, while the left upper limb is relatively less blue. While the right upper limb has got the bluish discoloration, which is similar to both the lower limbs. Okay, very good point. Yes, right. Okay, go ahead.
Now, sir, CVS examination. Sir, extra precordial examination, pulse 80 per minute, regular, high volume, not collapsing. Vessel walls not thickened, all peripheral pulses are felt, and no radioradial or radiofemoral delay. Yes, sir, here the volume is high, but sir, not collapsing because of the development of the Eisenmenger.
Okay, and also high volume pulse in a patient with the Eisenmenger syndrome is mostly associated with PDA. Very good, yes.
So JVP not elevated above the sternal angle, normal waves form. the blood pressure 130/70, so pulse pressure is 60 in the right upper limb, whereas in the right lower limb it is 140/70.
Okay, so a higher pulse volume also goes in favor of
PDA.
Yeah, but some of these patients with Eisenmenger sometimes can have slightly higher pulse volume because of the hypoxemia. There can be vasodilatation. So you will get their extremities can be warm, there can be vasodilatation, and sometimes there can be a slightly higher the pulse pressure. So that alone may not help you to diagnose PDA, but PDA is a strong possibility. Okay, right. Yes, go ahead.
Precordial examination, inspection and palpation. Apex beats seen and felt in the fifth intercostal space, fifth intercostal space on the mid-clavicular line. Forceful LV type. No sound or thrill felt at apex. The parasternal heave is present. S2 palpable in the second left intercostal space, close to the sternum. Pulsation are also felt in the second left intercostal space. No thrill. RV pulsation are felt in the epigastrium on deep inspiration.
Okay, interpretation.
Sir, it means, sir, there is a pulmonary arterial hypertension present.
Okay.
And sir, the apex is LV type. So, sir, in Eisenmenger physiology, LV type of apex suggests PDA.
Okay, one. Okay, what else would you like to think?
Sir, PDA with sir, pulmonary arterial hypertension with sir, RV also, sir, so because of pH, RV hypertrophy is RV pulsation are felt in the epigastric on deep inspiration. Means RV also hypertrophy.
Okay, RV pulsations can be prominent because of the pulmonary arterial hypertension, and also because of these patients can develop
failure, RV failure.
RV failure, or they can develop what regurgitation?
The tricuspid regurgitation.
PR. They can develop tricuspid regurgitation, they can develop pulmonary regurgitation, and because of that, they can have even volume overload as well as pressure overload because of the pulmonary arterial hypertension. So that can happen. Okay, that can be explained without any problem. LV apex is. Do you think this can be a single ventricle? Saroj.
Yes, sir. So single ventricle usually of LV type, sir, that can be explained, but sir, RV we cannot explain, sir, in single ventricle.
Very good. RV cannot be explained because RV is
rudimentary,
non-existent or rudimentary. Okay, right. Yes. So that's a point against the single ventricle. Can this be double outed right ventricle?
So double outed right ventricle will not have, sir, LV type of apex.
Why not? Okay. In what type of
if it is a restrictive ESD, then we can get.
Yeah, in a restrictive ESD with in a patient with double outer right ventricle, you can get the LV type of apex, and so that possibility you can keep in mind, and especially when you are looking for the echocardiogram, you should be able to recognize that. One point. Second, these patients will have a very prominent systolic murmur. Even in presence of Eisenmenger syndrome, you will be able to get in even presence of bluish discoloration, you will be able to get a prominent systolic murmur.
Systolic murmur for the pulmonary flows. Pulmonary restricted.
Because of the restrictive ESD. Because of the restrictive ESD, you should be able to get a good systolic murmur because of the flow across the restrictive ESD. Okay, right? Yes.
And sir, ASD also ruled out, so there is no cardiomegaly, so ASD also.
Yes, ASD, when there is a Eisenmenger syndrome, there need not be cardiomegaly. Usually the ASD gives rise to cardiomegaly because of the increased shunt. They can develop tricuspid regurgitation.
That will be of RV type, sir.
Yeah, then it will be RV type. So all those things, LV type definitely rules out the possibility of.
Sir, Austin secondum ASD. Austin primum can be possible.
Yeah, in Austin primum, because of the, if there's a prominent mitral regurgitation, some of these patients can have a LV type of apex also. Okay, right. Yes, go ahead.
Percussion. Cardiac dullness corresponds to the apex beat, and the second left intercostal has impaired resonance up to 2.5 centimeter from the sternal bottom. Right heart border is normal.
Okay, right.
So this again rule out the ASD
Very good, because in ISD we would expect
Sir, RA enlargement.
RA enlargement. Very good point. Yes.
Auscultation. S1 is normal, best heard at apex. S2 loud, best audible at pulmonary area. Normal split. P2 loud. No S3 or S4 is heard in the tricuspid area. Louder during the inspiration.
No S3, S4 is heard in the tricuspid.
Oh, sorry, sir. Okay, sir. No S3 and S4 is heard in the tricuspid area. Louder during the inspiration. And there is a loud constant ejection click. Best audible at the pulmonary area and less audible at the aortic area. There is an early systolic. So up to here, sir, the explanation, sir, is that, sir, there is S4 is heard in the tricuspid. So RB S4 is present, and sir, constant ejection click is present. It means, sir, it is a vascular click of pulmonary origin.
Very good. Yes.
And now, sir, there is an early systolic blowing, high-pitched.
Second heart sound, normal split. What does it indicate?
Sir, normal split, sir, sir, in PDA, if sir, split, sir, we can get all three types of split. Sir, if the split is normal, means, sir, pulmonary arterial hypertension has developed. So, sir, the A2 and P2 have, so which was in the beginning reverse split has become normal split.
Okay. Patients with PDA with Eisenmenger, patients with VSD with Eisenmenger, patients with ASD with Eisenmenger. What will be the second heart sound?
Sir, in case of PDA with Eisenmenger, sir, second heart sound will be normal split, sir.
Okay, you can get a normal split second heart sound in a patient with PDA. Okay, right? Yes.
And sir, in VSD,
can you get a single second heart sound in PDA?
Yes, sir. If it becomes more severe.
Yeah, by patients with the PDA can have a single second heart sound. What is the mechanism?
Sir, actually, in the PDA mechanism is in the beginning, the flow to the left side of the heart is sir more. Sir, as a result, sir, sir, A2 will be delayed. So, sir, there may be a paradoxical split.
Okay, A2 may be delayed due to two mechanisms. What are those two mechanisms?
Sir, one is the ejection time of the left side of the heart is more.
Because of the increased flow, volume of blood coming to the LV is more, resulting in a higher stroke volume. So the
A2 is delayed.
A2 can be delayed. Okay, right. 2.
And sir, second is that P2 can be early because sir, the flow from the RB is less and
RB flow is not less.
No, sir.
Hangout interval is. As patient develop pulmonary hypertension, so hangout interval will be short.
When they develop pulmonary artery hypertension, hangout interval can be short. And in a patient with PDA, what happens to the hangout interval? In a patient with PDA, what happens to the hangout interval?
Sir, it will be shortened.
Why?
Sir, when pulmonary artery hypertension will develop, then sir,
what happens to the hangout interval of the aortic valve in a patient with PDA? Not of the pulmonary valve.
Prolonged.
It will be prolonged. Why?
Sir, because sir, peripheral vascular resistance decreases.
Yes, peripheral vascular resistance decreases. That will result in a
increased hangout interval.
Increased hangout interval. So, in a patient with PDA, there are many hemodynamic changes which can result in early occurrence of the second heart sound P2 and delayed occurrence of the A2. So sometimes this is such that it can happen that the second heart sound can be single. So second heart sound can be normally split or second heart sound can be single also. Okay, right? Yes.
So VSD Eisenmenger, second heart sound will be single.
Yes, always single. When in a VSD Eisenmenger, it is always single. If the second heart sound is normally split or second heart sound is fixed split, that rules out the possibility of VSD. VSD always single second heart sound. Yes, very good. Yes.
And sir, in ASD, sir, it will be wide and fixed.
It may not be always. It can be wide and fixed. It can be normally moving, and it can be single also. How can it be in a patient with ASD? How can the second heart sound be single when there is Eisenmenger syndrome?
So because of the pulmonary artery hypertension, P2 will be coming early.
Okay.
Then, sir, it can be close split or sir single.
Yes. Because of the hangout interval is not there,
Decrease.
that can result in P2 can occur early, and that can sometimes result in single second heart sound. So single heart sound is not a point against the ASD.
Yes.
When ASD, you can get a single second sound. It can be sometimes normally split, or it can be wide and fixed split. In a patient with VSD, it is always single second heart sound. In a patient with PDA, it can be single second heart sound, or it can be normally split also. Okay, right. Yes. Go ahead.
Now, sir, sir, S4 is heard in the tricuspid area.
Yes.
Sir, it means, sir, there is a, sir, that also suggests, sir, pulmonary artery hypertension.
Yes.
Or RV end diastolic pressure is high.
Yes, there is
hypertrophy. There's
a RV hypertrophy resulting in reduced compliance with RV, and that has resulted in a fourth heart sound. Okay, right? Yes.
And, so there is a loud constant ejection.
What else can you think of? Because of does the presence of fourth heart sound make you think that is more likely to be PDA than in VSD? What happens in VSD? Is it common to have a fourth heart sound?
No, sir, we will not get, sir.
Why?
Sir, because sir, RV is decompensated to the LV.
Very good. When because there is a communication, good communication between RV and LV, the RV end diastolic pressure cannot significantly go up. These patients with fourth heart sound must be having some pathology in the LV also, like systemic hypertension or something which has resulted in LV pathology also. Otherwise, in a patient with VSD, fourth heart sound, the trachea of the RV is very unlikely because RV can decompress to the left side. But in a patient with PDA, where there is pulmonary hypertension, the RV cannot decompress during diastole into the left ventricle, and the fourth heart sound may be possible. So presence of a fourth heart sound goes more in favor of a PDA than ASD than VSD. Okay, right. Yes, go ahead.
There is an early systolic blowing, high-pitched murmur audible in tricuspid area and the left sternal border, increasing on inspiration, grade 3/6. So this is tricuspid regurgitation murmur.
Very good.
There is a mid-systolic, early peaking, rough murmur in the pulmonary area, grade 2/6. So possibly flow murmur through the pulmonary outflow. RV outflow.
How can there be a flow murmur across the RV outflow?
So there is a mid-systolic, early peaking, sir. So, sir, either flow murmur or, sir, mild pulmonary stenosis.
Is there any other explanation? So, for that brings us to the question, what are the mechanisms of a mid-systolic ejection murmur? Ejection systolic murmur. Mechanism of ejection systolic murmur.
So, that can be because of increased flow. That can be because of the, sir...
increased flow across a... You have to define...
Across a narrow...
For a murmur to be heard across a narrow well, there is no need of an increased flow. It can be a normal flow across a
normal vessel.
Normal flow across a stenosis well, as can occur in aortic stenosis, pulmonary stenosis. True.
So second,
normal
like in case of ASD or aortic regurgitation, flow murmur through the aorta and the pulmonary artery.
Increased flow across the
normal
well. Okay. Third mechanism.
Dilatation of vessel that lead to the turbulence.
Yes, the dilatation of the vessel, the valve opening to a dilated vessel can give rise to a mid-systolic murmur, as can occur in aortic aneurysm or a pulmonary dilatation secondary to pulmonary hypertension. Very good. Fourth mechanism.
Structurally abnormal walls.
Yes,
structural abnormal valve. No, even if they are not stenosed, structural abnormal valve can give rise to a systolic murmur. And example is bicuspid aortic valve. Fifth mechanism.
Hyperdynamic flow, sir.
hyperdynamic circulatory states. For example, anemia, thyrotoxicosis, beriberi, even some patients with pulmonary all can have a ejection systolic murmur. Okay, sixth mechanism.
Sclerotic walls.
So out of these 6 mechanisms, what is the one which best fits in here? Saroj?
Yes, sir. Sir, here.
Pulmonary artery dilatation, sir, due to.
Yeah, most likely due to pulmonary artery dilatation. We have got ample evidence that pulmonary artery is large because of the evidence.
Sir, constant ejection click also.
Yes, there's a constant ejection click. And in the percussion, second left intercostal space is impaired response up to 2 centimeters. They're all indicating that there is a significantly dilated pulmonary artery that can give rise to the mid-systolic early peaking murmur. Okay, yes. Why did you say there is an increased flow across the pulmonary vein? What is the mechanism?
Sir, I was wrong here, sir. It will be
see, of course, in a patient with AST, sometimes you can get an
no, sir. Yeah.
But can there be an increased flow across the pulmonary vein in this patient? You are not thinking.
No, yes. Yes.
Any one of you?
Because of PR, flow can be increased.
Very good, excellent. This patient is having a early diastolic blowing high-pitched murmur in the second left intercostal space, and this can be explained as or interpreted as a pulmonary regurgitation, and then there can be a higher stroke volume. Okay, right. Yes, go ahead.
So no change with the breathing, and this murmur is not audible in the aortic area, and no other murmur.
Okay.
So no abnormalities are detected.
No, you interpret that. What is this murmur due to?
Sir, this early diastolic blowing high-pitched murmur in second left intercostal space. This is a pulmonary regurgitation murmur.
Yes, by clinical auscultation, it looks like a pulmonary regurgitation murmur. Okay, right. Yes. So, based on the clinical findings, what is your first possibility? And then we'll go to the ECG and X-ray and further discussion.
So, congenital. Sir, should I say acyanotic or cyanotic, sir? I get confused now.
You can put as diplomatic congenital heart disease. To start with acyanotic, now has turned cyanotic.
Yes, sir. Yes, sir.
So make it diplomatic so that there is no problem.
Yes,
okay.
The congenital acyanotic heart disease. To start with, now cyanotic Eisenmenger physiology.
Very good.
Possibly patent ductus arteriosus with apparent right subclavian artery.
Very good.
With
you are right.
In sinus rhythm. With the history of hyperviscosity syndrome.
Okay, very good. Did you say PDA?
हाँ sir, yes, yes
okay.
Sir.
Okay. So,
NYHA class रह गया मैम, NYHA class रह गया.
Is the patient in heart failure?
NYHA
sir,
class
no.
2 to 3.
Not sir, JP not.
It is 3. NYHA class 3.
History they have written, sir, I think. History they have written it, sir.
Yeah, it is class 3. NYHA yes, class 3. You can include that also, NYHA class 3.
Class 3. In sinus rhythm?
Do you think that this patient may be having RV failure?
No, sir. Actually, S4 is there.
Yeah.
Yes. If RV failure is S3 should be there.
And also JAP is not significantly elevated. So probably our RV diastolic pressures are not significantly elevated.
And
no pedal edema also, sir.
No
pedal edema also. There is no pedal edema also.
On the basis of the clinical findings, we cannot diagnose associated RV failure. Okay, right. Yes.
So when Eisenmenger is told, then sir, severe PH is already implied.
Yes. Okay. So what do you like to see, ECG or X-ray test?
Sir, one thing, sir. Excuse me, sir. Sir, this on examination, sir, any this auscultation at the back, PDA was there, so anything on the back that we should mention or?
In a patient with Eisenmenger syndrome, you will not be able to hear any PDA murmur, but it may be worthwhile auscultating all over the lung field to rule out any continuous murmur, because you are looking for any aorta pulmonary collaterals, or always better to auscultate, and you can mention that no continuous murmur heard anywhere over the precordium or in the lung field. It may be worth mentioning that. So that makes the description complete. No continuous murmur heard anywhere over the precordium. So what are the continuous murmurs which may be associated with cyanosis?
First, MAFCAS is there. That
yes, patients with significant pulmonary valve or maybe even pulmonary atresia, these patients can have.
So multiple aortopulmonary communications.
Yes, which can give rise to continuous murmur. Okay, 2.
Sir, AV fistula.
Very good. Pulmonary arterial fistula can give rise to continuous murmur. Okay, right. Is any other?
EAPVC, sir.
Very good. Sometimes you can get a continuous murmur in a patient with TAPVC. Where do you hear the continuous murmur?
So at the back?
Not at the back. Is it more common in cardiac, infracardiac, supracardiac type of VSD, TAPVC?
Supracardiac.
Supracardiac. And what is the mechanism?
So there can be obstruction at various levels where the innominate vein joins the SVC.
Very good. There can be obstructions at various levels, but the most frequent way which can give us to continuous murmur is when the vertical vein joins the SVC. When it joins the SVC at the junction, there can be a narrowing, and that can result in a continuous murmur. Very good. So continuous murmur may be associated with, can occur in a patient with total anomalous pulmonary venous drainage, and that patient can have cyanosis. Yes. Any other?
The post-BT shunt.
Yes. Patients with what's called a BT shunt, man-made shunt, can have a continuous murmur and can have a bluish discoloration. So these are the few conditions where you can get a continuous murmur and bluish discoloration. And in this patient, there is no continuous murmur, and so the differential diagnosis that we have mentioned does not come in. And usually PDA, once the PDA, VSD or ASD, whatever it is, when they develop Eisenmenger, the classical murmur secondary to the original VSD and PDA will not be there. You will hear only other murmurs like ejection systolic murmur or the pulmonary arterial hypertension, which will be more prominent. Okay, right. Now, what would you like to see? ECG or X-ray chest?
Sir, ECG, sir.
ECG. Why are you saying you would like to see ECG?
Sir, because from the ECG, sir, we will be able to first, sir, make out the pulmonary arterial hypertension, whether suprasystemic present or not. Then, sir, chamber enlargement, axis.
Yeah, you can look at whether the patient
and sir, loop.
Evidence of any if you can pick up LV forces, that will be more in favor of
PDA.
PDA. Okay, right. Yes. But in X-ray chest also is useful in PDA.
Yes, sir. X-ray also we can see.
Calcification and sir.
No cardiomegaly is there or not? Other things we can see.
Inverted 3 side.
Yeah. Inverted 3 sign is not a feature.
Oh, sorry, sir. That is coarctation. Sorry.
You can look for
dilated aorta.
Yes, dilated aorta, especially arch of aorta can be dilated, and also you can look for
calcification of the PDA.
Yeah, very good. Duct can be calcified. Okay, right. Yes. Okay. Yes. Yes.
So this is 12 lead ECG.
Okay.
Sir, sinus rhythm. Sir, P waves. Sir, 1 minute, sir. In V1. Yes, sir. Sir, biatrial enlargement is present.
Very good. Excellent. Very good.
Sir, PR interval is borderline high, sir. It is 0.20. Just
0.20 is normal. Upper limit is normal.
So little 6. Yes, sir. Okay, sir. And now, sir, the axis is just 0 degrees, sir. Because,
Okay.
Sir, 90 degrees, sir. Sir, because one is isoelectric.
Eh?
Lead 1 is isoelectric, na, sir?
Okay, right. You're right. Lead 1 is isoelectric, so the axis would be near about 90 degrees. Okay,
90
right.
degrees.
Very good. Yes.
Sir. And sir, there is criteria for left ventricular hypertrophy fulfilling, sir. Sir, single lead criteria also fulfilling. And sir, also, sir, that so there is also, sir, biventricular hypertrophy, sir.
That's
In
evidence
V1,
of, there is evidence of right as well as left ventricular.
Sir, so biatrial enlargement and biventricular hypertrophy.
Yes.
Which, sir, sir, LV is showing, sir, volume overload type of hypertrophy.
Right.
But, sir, because the T waves are upright,
Okay.
the QRS are narrow, and sir, I think, sir, tiny Q waves are also seen in V5 and V6.
Okay, so you are thinking that there can be a volume overload like a pattern in the
LV.
And
but sir, in RV, sir, it is like sir, T waves are inverted with very prominent R waves in V1, V2.
Okay, in V1, so that also indicates associated right ventricular
hypertrophy.
Okay, so both biventricular involvement and both the mitral both the atria are dilated. How will you explain it?
And patient in sinus rhythm, and there is a no.
And sir, PA pressure around 80, sir, because V1 we can see around 15 or PA pressures are around 80 or 90, sir, because V1 we will see that R wave is around 17. 17 into 5 around 85.
What is the formula for that?
So that is applicable only for pulmonary stenosis. Sir, 5 into small squares.
Yes.
Number of small squares.
17 into 5, so it will be 85. It will come around 85.
So the pressure can be around 80 to 90. So from the electrocardiogram, you can say that most likely the pressure will be around 80 to 90. It can be even higher also, but definitely near about 80 to 90. Okay, right. Go ahead. Any other point from the electro? I asked you a question. How can you explain the biatrial enlargement?
So biatrial enlargement, one, sir, in lead V1, sir, biphasic is seen, sir, and whereas, sir, V1.
In a patient with PDA, how are you going to explain this biatrial enlargement?
Sir, yes, sir. After development of pulmonary artery hypertension, patient has developed TR. Then, sir, we can explain both biatrial enlargement.
Okay, that can explain right atrial enlargement. What about left atrial enlargement?
So, left atrial enlargement, sir, it is in the sir, in the beginning only, sir. Sir, PDA without pulmonary artery hypertension, LA is enlarged, LA and LV.
Very good. But when the patient has pulmonary hypertension, does that mean that the LA enlargement is not there?
No, sir. It will not regress, sir.
Do you think that really there is a left atrial enlargement, or you think that it is doubtful?
Oh, sir. Yes, sir. That yeah, sir. Sharply, sir, coming down, sir.
And also the negative comment is not very prominent. So there is definitely a right atrial enlargement, and the left atrial enlargement is very unlikely. Okay, right? Yes. Okay. Would you like to see the X-ray chest next?
Yes, sir. Yes.
Okay.
Sir, X-ray chest PA view showing, sir, mild cardiomegaly is present, sir, up to 60%. So there is a huge dilatation of the sir, MPA and also, sir, RPA. Sir, there is calcification also seen, sir.
Yes, you can see the calcification here.
Yes, sir. Both, sir. Sir, PDA as well as the pulmonary artery.
I don't know, pulmonary artery is calcified or not. Definitely there is a calcification process which...
yes, sir.
There's a calcification.
Yes, sir. Double.
What is this?
So this is aortic knuckle.
Yes, aortic knuckle is also prominent.
Yes, sir.
That also goes very much in favor of
PDA.
And also there is a
pruning is present, sir. Peripheral pruning is present.
Yes, there is a hugely dilated
RPA.
And what is happening to LPA?
Sir, LPA not seen, sir. It is going back, sir.
So what do you think? What is the problem?
So then
Rotation.
no, sir. There may be sir, that aberrant subclavian artery was present.
That has nothing to do with the.
No, sir. Sir, RPA, sir. It means, sir, some.
Can you
Sir, left pulmonary artery stenosis.
Yeah, left pulmonary artery stenosis. You can suspect left pulmonary artery stenosis. So if you are suspecting PDA with left pulmonary artery stenosis, what is this combination?
Sir, that is, sir, syndrome, sir, Alazilla or, sir,
in rubella syndrome also, you can get
yes, sir,
you can get PDA with peripheral pulmonary artery stenosis. So looking at the X-ray, you have to suspect whether there is a associated left pulmonary artery stenosis and whether this is whether the patient had is a case of rubella syndrome or not. Okay, right. Yes, go ahead. So there are enough features.
And the arch, sir, aortic arch, sir.
Yes, aortic arch is normal left side, and there is a prominent aortic knuckle. All right, right. Okay, now coming to the echocardiogram. Okay.
Sir, this is a M mode at the level of mitral valve.
Okay.
Which is shows that flattening of the septum, IVS. Suggests, sir, and RV is so much hypertrophied, sir. RV free wall.
Okay, very good.
And sir, there is a flattening and
RV free wall is not measured here, but I don't know whether it is really hypertrophied or not. Maybe some hypertrophy maybe from here to here.
Okay, sir.
So I agree with you. There may be some degree of RV hypertrophy. Okay, right. Yes, go ahead.
Now, sir, coming to the, sir, at the aortic valve level, sir, LA and aorta, sir, they are of normal size, sir. Okay. And, sir, normal central closure of the aortic valve. And
okay, so there is no structural abnormality of the aortic valve. Okay.
So this is a plaques view. The first one, sir, showing, sir, sir, in the second view, sir, parasternal short axis view, we can see the D-shaped LV.
Yes, there is a the normal curvature of the endoventricular septum is lost and it has become flat, and the LV has attained the shape of the D shape.
Yes, sir.
Suggestive of?
So suggestive of RV pressure overload.
Yes. Pulmonary hypertension and consequently the RV pressure is sir. Okay, right, yes.
And sir, in the plaques view, septum looks more thicker, little more thicker than the posterior one.
Okay, right, yes.
And sir, in the color flow, sir, color flow mitral valve and aortic valve normal, sir, but some turbulence is seen in near the RV, though not very well seen, sir. That much.
Why do you say the turbulence in an echocardiogram? How will you detect the turbulence?
So, just that mosaic pattern is seen in RV.
Yes, if there is, you have to see a mosaic pattern. Is there a mosaic pattern there?
Sir, it's little.
No, there is no definite mosaic pattern. You will have to look at the RV outflow better in the next view before you to make that comment. So here it does not seem to be a big turbulence. Okay, right, yes. This is showing the D sign, which is suggestive of pulmonary hypertension. Yes, what are the abnormalities in this echo?
Yes, sir. Sir, plaques is the same, sir. Sir, here, sir, parasternal short axis view at the aortic valve level is showing. Sir, at the pulmonary valve, little, sir, looks thickened, and sir, MPA looks a little dilated,
Especially the bottom one shows the MPA significantly dilated. Okay. Yes.
And sir, now sir, come to the M mode at the pulmonary valve level, sir. That A notch is seen, sir. In the M mode, sir. Last one.
Very good. And the A notch is not seen, and also there is a mid-diastolic closure.
Yes, sir. Mid-diastolic closure is present, sir.
Yes, there's a
mid-diastolic closure at the M mode of the pulmonary valve.
Yeah, very good. That suggests what?
Sir, that suggests, sir, pulmonary hypertension.
Yes, pulmonary hypertension. Okay, very good.
Now, sir, this also, sir, again, sir, showing the pulmonary valve level. Sir, the pulmonary MPA is dilated, sir.
Very
and
good.
Sir, pulmonary valve closure is not, sir, it is not complete, sir. Maybe, sir, pulmonary regurgitation may be there.
Okay.
And, sir, at the, sir, fourth, so this one is a pulmonary valve level, sir. The gradient only 13, sir. So no pulmonary stenosis.
Okay, good. What about these two? Any?
Sir, here LA is compressed, sir. In the apical four chambers, sir, whether LA is compressed and RV is hypertrophied. Sir, compared to the LA, RA is little prominent.
Why the LA is compressed?
Sir, maybe, sir, because of the pulmonary, dilated pulmonary artery can come.
Oh, can the pulmonary artery go behind the
no, sir. No, sir. Sir, usually
compress it.
No, sir. No.
Yeah,
what is that structure which is compressing the? We also had great difficulty in interpreting what may be the reason. Only one particular view that you can see the step of a compression. And ultimately, I thought it may be the vertebral body which is compressing the left atrium. Okay, right. Go ahead.
Now, sir, that same view, sir, that the right side apical four chamber view, sir, RV hypertrophy, RA dilated.
And also, you can see that intrathecal septum is well seen.
No flow across the IS.
There is no ASD. Okay, right, yes. Okay, what is this?
Sir, tricuspid regurgitation is seen, sir, significant, sir. It is reaching up to, sir, SVC.
Yes.
Yeah, so we have to see the gradient. Gradient is 113. Sir, so it is, sir, severe pulmonary artery hypertension.
Okay, so there's a significant gradient which is around, the gradient is 113 plus 10, so the pulmonary pressure
123.
About 125, so it is equal to systemic pressure. Okay, right, yes.
So this is the mitral inflow velocity, sir. This is, sir, E by A, sir. So little A is more than E, sir.
Yes, okay, not very significant.
Not very significant, sir. And aortic valves are normal, sir. Only gradient is 3, so no turbulence seen in the aorta.
So you didn't see any ASD, you didn't see any VSD, and you didn't demonstrate any PDA also. So there are many features for you to ultimately say that this could be a PDA.
Yes, sir.
Eisenmenger. Okay, right, yes. Echo D, you didn't demonstrate the PDA. So what will be the diagnosis?
Congenital heart disease, cyanotic Eisenmenger syndrome, PDA, bidirectional shunt, mostly right to left, TR, mild, PR mild, aberrant right subclavian artery, normal sinus fever.
Okay, right. So few points. What do you mean by Eisenmenger syndrome? Can you define it? And can you tell me who defined the Eisenmenger syndrome first and what is the definition?
So, Paulwood, sir.
Oh, yes, Paulwood. Very good. And what is it?
Sir, Eisenmenger syndrome is, sir, at the level of VSD, whereas, so rest all are said to be the Eisenmenger complex.
No, it is the other way around.
Oh, sir, sorry.
But nowadays we use the word Eisenmenger syndrome for all the three. We need not distinguish. Okay.
Sir,
so this is the definition. You can read it.
yes, sir. Definition: the term Eisenmenger syndrome refers to the patients of increased pulmonary blood flow, developing systemic levels of the pulmonary artery pressure and pulmonary vascular resistance equal to or more than 10 units, 800 dyne per centimeter, associated
raised to the power of -5.
Yes, sir. Associated with right to left or bidirectional shunting, characterized by central cyanosis.
Yes, that is the definition which was given by Paul, and so far nobody has modified it. So the Eisenmenger syndrome is the term. Eisenmenger syndrome refers to patients of increased pulmonary blood flow, developing systemic level of pulmonary artery pressure and pulmonary vascular resistance equal to or more than 10 Wood units or 800 dynes per centimeter raised to the power of -5, associated with right to left or bidirectional shunting, characterized by central cyanosis. Okay, right. Yeah. Yes, read.
Mainly involves the vessels less than 500 micrometer in diameter, grade 1 median hypertrophy, grade 2 intimal proliferation and fibrotic changes, grade 3 adventitial thickening with moderate perivascular inflammatory infiltrates, grade 4 complex lesion like plexiform or the dilated lesions, ruptured vessels or the thrombotic lesions.
That is the reason for the patient to develop hemoptysis. Okay, right, yes.
Grade 1 pulmonary artery hypertension, which includes idiopathic, heritable, drug or there are 5 types of the PH. So
yes.
Grade 1 includes a idiopathic, heritable, drug or toxin-induced or associated.
Group, yes, group 1. PH.
Yes, sir, group 1. Yes, sir, group 1. Yeah, 5 groups. Yes, sir. Heritable, drug or toxin-induced associated with congenital heart disease or connective tissue disease. Sir, then sir, pulmonary veno-occlusive disease, the persistent pulmonary arterial hypertension of newborn. So
all this come under the category of PH, which with all this category, including primary pulmonary arterial hypertension. Okay, right, yes.
Group 2, it is due to the left heart disease.
Okay.
Group 3, it is due to the lung disease.
Okay.
Group 4 is chronic thromboembolic pulmonary hypertension.
Very good.
Group 5, pulmonary hypertension due to the unclear or the multifactorial causes.
Okay, yes.
Eisenmenger syndrome complications, hemoptysis, sometimes massive, resulting in death. Congestive heart failure usually occurs after the age of 40 years. Stroke, brain abscess, sudden death, maybe arrhythmic.
Yes.
Natural history, patients with a large and free left to right shunt, as in AP window or total anomalous venous connection. The Eisenmenger syndrome develops early in the life, in the first decade or early second decade. Large VSD or PDA develops Eisenmenger syndrome by late second decade. AST patients can develop early Eisenmenger syndrome late in life, even in the 4th or the 5th decade. However, a small percentage, 5 to 10% of the AST patients can develop Eisenmenger syndrome early in life. These patients are thought to have pulmonary vascular pathology similar to primary pulmonary arterial hypertension. Survival up to the 5th decade is common. PDA has the best survival after the development of Eisenmenger syndrome. This is because the cerebral circulation still receives the oxygenated blood.
That's what you should remember. That in a patient with PDA, the brain and upper limbs are still supplied with mostly oxygenated blood. And because of that, these patients with PDA with Eisenmenger syndrome have got much better prognosis compared to other patients with Eisenmenger syndrome. Because brain still gets oxygenated blood. Right, okay, yes. And also they don't have a brain abscess. Problems related to brain like brain abscess do not happen. Most very unlikely in patients with PDA. Okay, right, yes.
Causes of death are sudden death, 30%, congestive heart failure, 25%, massive pulmonary hemorrhage, 15%, the remaining due to the miscellaneous causes like brain abscess, pregnancy, or in case of non-cardiac surgery.
Sometimes any surgical procedure can cause deterioration of these patients, and they may succumb to it. And pregnancy is contraindicated in patients with Eisenmenger syndrome.
Eisenmenger syndrome management. General measures: adequate hydration, iron supplementation if required, influenza and the pneumococcal vaccination, venesection, high risk of non-cardiac surgery under GA, avoid GA, nocturnal oxygen therapy.
At night, they can be given oxygen therapy, and these patients do very well because their oxygen saturation can improve at night, and they will be much better off. So that is another method. And also, you can these patients are prone to develop recurrent respiratory tract infection, and influenza and pneumococcal vaccination should be taken. Okay, right? Yes.
Drugs to reduce the pulmonary artery pressure. Drug treatment, classification of the drug: prostacyclin modulation, endothelin 1 receptor antagonist, 5-phosphodiesterase enzyme inhibitors, soluble guanylate cyclase stimulator. Prostacyclin modulation, IV prostanoids, treprostinil inhalation, or Selexipag oral prostacyclin receptor agonist.
Now, the Selexipag is now available in our country, and this can be used. And what is the dose of Selexipag, Saroj, or anybody?
6 milligram.
No.
No. I don't know, sir.
It's usually available in tablets of 200 and 400 micrograms, and the dose is 200 micrograms twice daily. And Selexipag is it's a prostacyclin receptor agonist, and thereby can improve vasodilatation and can result in less of pulmonary artery hypertension. What is the problem of giving these vasodilators in a patient with Eisenmenger syndrome?
Hypotension.
One is hypertension. Second, they can also cause systemic vascular dilatation, and sometimes there can be an actually increase in the right to left shunt because of the systemic vascular resistance effect may be more than the pulmonary vascular effect, and that can result in a right to left shunt.
So endothelin receptor antagonist in 2006 BREATH 5 trial. So bosentan, ambrisentan, macitentan.
Macitentan. Yes. And all the three have been tried, and macitentan is associated with the least toxic side effects.
Yes, sir. Yes. Only, sir, a little anemia and, sir, edema. Sir, macitentan.
Yeah, but it is usually as well compared to other two. Other two, less of toxic.
Bosentan has got a severe liver side effect.
Yes.
And sir, moreover, sir, usually, sir, transplant patient, we cannot give the transplant drugs with the bosentan.
Oh, I see. That I did not know. What is the problem?
Sir, because sir, they are with the that's a PY inhibitor from same pathway. They will also degrade that cycloserine and that valuable drugs of the transplant, post-transplant.
Oh, so the post-transplant drug toxicity will be more, is it?
No, sir. No, sir. They will not work. Sir, they will washed out fast.
I see. Oh, I have not read that, so I do not know.
Sir, it is a new update given, sir.
Oh, I see. Oh. So that is
sir, bosentan we cannot give, but sir, ambrisentan and macitentan we can give.
Oh, okay, fine. I will verify that point. I have not read that, so I have to verify that point. Okay, very good. Yes.
And sir, 5-phosphodiesterase enzyme inhibitors, sildenafil and the tadalafil, sir.
Okay.
And soluble guanylate cyclase stimulators, riosiguate, and sir, another, sir, versigouate has come for the heart failure, no?
Okay, yes.
Yes, sir.
Increases
the sensitivity of soluble guanylate cyclase NO combination therapy. Sir, here we have to be careful that we should not give with sildenafil and tadalafil.
Yes. This riosiguate should not be combined with 5.
Sir, because severe hypotension, sir, both are NO donor.
Yes.
Now, sir, surgical treatment, lung transplantation with the correction of cardiac anomaly, heart lung transplantation, 5-year survival in some cases is as high as 50%, And in most of the reports, the 50% survival is up to 3 years.
Yeah. So that is that's all about the pulmonary artery hypertension. And
Yes, so nowadays, some other methods are also being chosen, sir. So, like, sir, balloon arterial septostomy, sir, sometimes is done.
That is useful in patients with primary pulmonary artery hypertension. I do not know whether it is useful because already there is a
okay, sir. Yes,
outlet for the Eisenmenger syndrome, but patients with primary pulmonary artery hypertension, sometimes if they are developing more and more symptoms, you can try septostomy.
So this pulmonary hypertension treatment we read in journal, na? So it is in general.
Yeah, it is in general, yes. So this applies to any primary pulmonary artery hypertension, but this surgical treatment that is specific for Eisenmenger syndrome.
Yes.
Okay, right. So any doubts, any points that anybody wants to clarify, you can ask now.
So nowadays in idiopathic pulmonary artery hypertension, sir, like renal denervation, pulmonary artery denervation is also being tried.
Yeah, I also read that. So but it is still not completely confirmed. But there is a nerve denervation maybe is being tried, whether that can help in reducing the pulmonary artery pressure. Yes, that's still in the development stage, and it may take some more time before it can be more. It can be proved beyond doubt, and then it can come into clinical practice. Okay, any doubts about any student, anybody having any doubt, you can clear it now. So it's all about patient with pulmonary artery hypertension, especially Eisenmenger syndrome, its management, complications, both medical, surgical. The medical management is applicable for any patient with pulmonary artery hypertension, and surgical is a little more specific for Eisenmenger syndrome. And some of the centers where there is heart lung transplantation is being carried out, there are some patients with 5-year survival as high as 50%. Okay, if there are no more doubts, and I think we'll end today's discussion. And what would you like to have next week? Case discussion, or you would like to go for spotters or something else? What do you want? Do you want the case discussion to continue, or you would like to have some spotters? We can have a spotter. I think let's have a change. We had 2 sessions on case discussion, and next week we will have a spotter session. Okay?
Yes.
Okay, right. Okay.
Thank you, sir. So from here now, I'm ending this meeting.
Yeah, you can stop the meeting. You can conclude.
Okay. Thank you, sir.
Thank you, sir.
Hello.